And so what I want to talk today is about advanced plaque analysis, and is there a role for this clinically today? You saw some of the features, and I think this is important because we're seeing a dramatic paradigm shift. This was just so eloquently highlighted to us. We've now seen, led by our colleagues in the UK, a shift to plaque and anatomic imaging now replacing functional testing. And so this population around the world of patients who will undergo CT angiography is growing exponentially, and we're seeing this happen led by the UK, but certainly around the world as our guidelines shift. And we're all aware of ESC guidelines in 2019 and 2020 for chronic and acute chest pain syndromes respectively. And of course, the US finally caught up in 2021, making CTA the only non-invasive test for coronary disease to give it a class 1 level evidence A. And so we're going to be seeing a lot of plaque. We're going to be imaging a lot of plaque, and the question is, how are we best to assess it and utilize that information from scans that have already been done to try to integrate that into better managing patients? And I say we're living in a plaque world, and I think David Newby and Michelle Williams taught us this from SCOT-HEART, that it's really when you utilize plaque to guide preventive care, this concept of plaque-guided prevention that I think is going to overtake how we do prevention today. And the question is, well, first off, CT does pretty well, right? So as a technology, if you're going to say, can you do advanced plaque analysis? Well, regular plaque analysis is a tough thing to beat, right? You just saw all of the variety of information that we obtain from plaque in Dr. Narula and Dr. Sroy's talk. And this concept, of course, that you cannot treat what you don't see, and CT allows us to see things that our functional tests simply don't. And we've learned from PROMISE that the majority of events, unfortunately, in functional testing occur in patients with normal functional testing, and that almost all events, of course, occur in patients with plaque. And so CT's hard to beat, and this, you already are aware of the current approaches that we look at, obviously, a lot of parameters. Clinically, stenosis, right? Stenosis still matters. It's actually an adverse and high-risk plaque characteristic. We know this from IVUS data as well when you look at MLA. So stenosis, while it gets a bad name, still matters. But we look at other things, and this is, again, data from PROMISE, and you've seen this really led by Sadeki Motoyama's work with Dr. Narula, who taught us that it's, in fact, plaque characteristics that also really matter, in fact, augment our assessment of stenosis. And so just doing this qualitatively, we can get a lot of information. Regular coronary CTA is tough to beat. But here's the challenge, is when you open the hood, right? And we'll talk a little bit about what is the reproducibility of this put in clinical users. Well, I just want to point out that plaque is now paramount. So this is the updated CADREDS 2 document. I had the pleasure of being a co-author in this with Dr. Williams and a few of you in the room. And this really made plaque paramount and central to reading CT. The old way of reading CT was really read like an invasive angiogram. It was semi-quantitative stenosis only. And this integrated, stating that all CT scans done today should be reported to have a plaque score. But how do we do this? Well, again, it either says, well, did you do a calcium score? You can count the number of segments with any plaque, or you can just eyeball it, right? And we know that there are significant potential drawbacks to this approach. And I'll just point out that, of course, within CADREDS 2.0, again, are the high-risk plaque features. And so this is where we're at today, a semi-quantitative assessment of plaque, calcium scoring if done, which is done in about 70% of CTs done today, as well as a dichotomous HRP positive, HRP negative, right? Well, here's the challenge. We've known this for a while. This is going back to CADREDS 1.0. This is published back in 2018, is that experts agree generally pretty well on stenosis. Now, we all know that in intermediate stenosis, it can be challenging, but what they don't agree well on are these things. And these things I mentioned may matter, right? In fact, you can see very poor agreement for high-risk plaque. And remember, the CADREDS, you have to have 2 of these in a single plaque, and you're documented as positive or negative in a dichotomous way. And so there may be some significant limitations, and this relates to training, this relates to image quality, and this is one of the kind of downsides that we see. And we've learned, again, from Dr. Williams, that in fact, advanced plaque analysis can be a game changer. In fact, we've learned this, if you look within SCOT-HEART, there was an advanced plaque analysis tool able to quantify the plaque burden of low attenuation plaque that was independent to calcium scoring clinical risk factors and stenosis, and only modestly correlated with these things. And in fact, if you had a high burden of low attenuation plaque, you can see the significant increased risk of incident MI. In fact, it was the strongest predictor. And this is where I think quantitative and advanced plaque analysis can do this. And you saw these beautiful images from Patrice, but looking at those with my eye in a CT lab in a dark room, I can't tell you, did I see a plaque burden change of 4%? These are challenging to do anatomically in patients. And we know from additional studies, again, that how well are readers even able to estimate the burden, in fact, the proportion of plaque that's non-calcified visually. I've heard a lot of people say, well, I can just look at this and say it's mostly non-calcified, therefore it's high risk. And this was a study that, in fact, asked that question. They took 3 level 3 readers. They looked at 233 coronary CTA cases with a variety of disease severity. And they said, well, why don't you estimate into these quintiles the proportion of non-calcified versus calcified plaque, as well as high-risk plaque, and they compared it to an advanced AI-enabled software. And what you can see is that very poor agreement with the AI software for proportion of non-calcified plaque, and you can imagine that would even go lower for low attenuation plaque, as well as high-risk plaque features compared to software. Now, who's right? I don't know, but I think there are limitations in our current quantitative approach to interpreting CT. And we know we leave a lot on the cutting room floor already. And this is data from Paradigm, which was a nested case control study within the confirmed registry, which we were a part of, and it looked at patients who had clinically indicated serial CT scans and asked, well, what is most predictive of rapid progression? And here, based on prior literature, rapid progression was defined as PAV of progression of greater than 1% annualized. This is annualized. And in fact, the biggest predictors were all volumetric and things we're not currently measuring or reporting in our current clinical CT reads. It's things we can do, but are not clinically available. We're leaving this on the cutting room floor. And models, I'm not showing you the AECs and things, but models using this volumetric data significantly outperform stenosis, and individual high-risk plaque features were actually relatively less predictive than volumetric measures. And so this is kind of, are these prognostic? Can we better predict who's going to have events using quantitative measures? And in fact, it turns out we can. And so changing the way we think about coronary disease, using terms like percent atheroma volume. And again, this was a recent publication, it's actually just currently electronically, that used advanced plaque analysis. These were patients at a single center referred for PET imaging, so not certainly a selected population, who looked at 10-year follow-up according to the burden of disease quantified by the software, and compared this to calcium scoring risk factors and even the new CADRADS 2.0, which includes a plaque score. And what did they find? Well, again, not surprisingly, that when you look at 2 years and 5 years, there was the largest difference in area under the curve by using a software-based quantitative approach as compared to CADRADS to calcium scoring. This is a little bit of attenuated over 10 years of follow-up. It's a relatively small group, and it did include revascularization as an outcome. But when you look at, could we use plaque, advanced plaque, to reclassify risk? And this is what they showed at 10 years, is that, again, your PAV significantly predicted patients most likely to have heart events within this population was superior to what we know clinically and by calcium scoring. And so we know there's a variety of different approaches. I'm Chief Medical Officer at Elucid. I continue to do clinical work at Virginia. And so this is what's exciting about the field, is that there are a lot of different approaches for advanced plaque quantification. Most are rich quantified plaque, as I just mentioned, according to Hounsfield units. And we can talk a little bit about the challenges with that. We know that intrinsically, that pathologically, these tissues have a variety of Hounsfield units. So that's one of the challenges with using a strict Hounsfield unit approach. And we attempt to overcome that at Elucid by training models based on histopathology. But again, getting histopathology from the coronaries is challenging. And so we've done this in a carotid environment, trying to go beyond just strict Hounsfield units and identifying the patterns of plaque as they appear across different KVPs. And so far, so good. More to follow as we continue to validate our product. And this gives us the potential of using this. This is something we've used our software for, is looking at plaque regression, progression. And this is a case of psoriatic arthritis patients treated with a novel biologic who we saw regression in lipid-rich necrotic core. Now, it's important to understand the limitations of quantitative plaque. I mean, I'm sitting here saying this, I think, can really help patients move above and beyond what we're currently reading, but it needs good image quality. It needs good image quality. And we also need to understand the influence of KVP. And we've learned this from Paradigm. When you rescan patients at different KVs, you get wildly different measurements in low attenuation plaque. If you're using low KV and you have high lumen attenuation, your likelihood of measuring low attenuation plaque goes down dramatically. in the same patients, even if you image them within a very short period of time. And so how we image patients matters. This is something that does not get talked about enough. It's not probably incorporated into our software enough, and we need to do more research to standardize according to acquisition what we do. Now, of course, photon counting CT will change all of this, and many of these limitations will be overcome by that. And then lastly, the integration of plaque, it may help us inform biology. So we've talked a lot about FFRCT, and we know that in fact, plaque actually, this is a machine learning approach looking at predictive measures of plaque on an abnormal invasive FFR. And this is something that we're working on as well, this plaque-based FFRCT. But of course, what was shown is that many of the most important functionally significant predictors of an abnormal invasive FFR, in fact, are plaque-based. And I think this is the potential of leveraging this. And the last thing I'll say before I close is just that we're obviously focused on the coronaries, many of you, and most of the talks here are, but remember there are millions of CT angiograms done of the head and neck. And this also has the potential, up to 1 in 5 strokes are atheroembolic related to carotid artery disease. I can't think of a disease where plaque probably matters even more. People aren't getting head angina. It's really all about plaque risk in the carotids. And I think software has the ability, if you think about our indications for revascularization, they're antiquated, they're totally stenosis-based, and it ought to be plaque-based when event rates in carotid patients are exceedingly low. And selecting patients for revascularization probably should be guided by plaque and not stenosis. And we've done some work in this area showing that in fact, and others have as well with MRI and with CT, that if you characterize plaque, it is universally superior to stenotic measurements and clinical values. So I think in conclusion, coronary CTA is really good currently, right? We know it's better than functional testing, but it's qualitative and it still has high inter-reader variability, and then perhaps quantitative plaque analysis with these advantages may be able to help us. It also may provide reference ranges based on numbers. How do I compare against my age and sex matched peers, and serve as a baseline in patients who get scanned after initiation of therapy or clinically get scanned down the road to better assess progression in a quantitative way. So thank you.